I'd like to thank the department for the opportunity to present our work. Today, I'll be talking about emergency department visits after ambulatory surgery. Postoperative emergency department visits are a costly component of postoperative care that may be partially preventable. The frequency of these visits after ambulatory surgery has not been well described, and the rates at freestanding versus hospital-owned centers have not been directly compared. We investigated the rate of postoperative ED visits after ambulatory surgery at freestanding and hospital-owned surgery centers. We identified patients in the Florida, New York, and Wisconsin State Ambulatory Surgery Database, an ARC-HCUP maintained database of all ambulatory surgery discharges in these states. We selected adult patients undergoing elective same-day discharge, cholecystectomy, transurethral prostate resection, and laminectomy. We excluded patients with a record of ED visit charges from the same day, and each procedure type was considered separately in our analysis. We stratified our analysis based on whether or not the operation was done at a freestanding ambulatory surgery center, a FASC, or a hospital-owned surgery center, a HOSC. Freestanding centers have no affiliation with an American Hospital Association verified hospital, while HOSCs are affiliated with an AHA hospital, but do not necessarily have to be on the same campus. Our primary outcome was postoperative ED visit within 30 days, and our secondary outcome was a primary diagnosis code associated with the ED visit. Risk-adjusted rates were calculating using multivariate models and subsequently derived observed to expected ratios. Adjustment was done separately for patients with and without a history of prior admission. And for patients with a prior admission, comorbidities were extracted from prior discharge records, and Alex-Hauser comorbidity scores were calculated. For patients without a prior admission, risk adjustment was based on demographic data alone. We identified a total of approximately 116,000 patients undergoing cholecystectomy, approximately 18,000 patients undergoing laminectomy, and 14,000 patients undergoing TURP. While only 5% of patients had a cholecystectomy at a FASC, nearly 44% of patients having a laminectomy had surgery at a FASC, and about 25% of patients undergoing a TURP. Patients with prior admissions were more highly represented in the population of patients who had surgery at a HOSC, and this was true across all operative groups. The mean Alex-Hauser comorbidity score was also significantly higher for patients undergoing surgery at a HOSC, though the absolute difference was small, not greater than 1 in all groups. Risk-adjusted rates of ED visits were higher at all time points following surgery at HOSCs, for all operative groups, and for patients with and without prior admission, with the exception of patients who had cholecystectomies after a prior admission. The difference in ED visit rate ranged from approximately 0.5% to over 3%. To better understand the causes of ED visits, we extracted the primary diagnosis codes for each ED visit in the postoperative period and mapped the trajectory of these codes over time. Figures for ED visits following TURPs are shown, with causes shown in blue representing diagnoses thought to be most directly related to the procedure, such as a surgical site infection or postoperative catheter issue, while those shown in red represent causes unrelated or more distantly related to surgery. At all time points, there was no significant difference in the total proportion of visits related to postoperative complications. For patients undergoing TURPs, we did further investigate the rate of postoperative surgical site infection or urinary tract infection. And similarly, there was no difference at any time point between patients who had surgery at a FASC or a HOSC. In summary, patients undergoing surgery at a HOSC had higher postoperative ED visit rates than patients who had surgery at a FASC. And while some of this may be attributable to patient factors, this likely doesn't account for all of the difference. Factors that account for this gap may include process of care measures, such as how well a patient understands their discharge instructions, access to alternate sources of care, such as an outpatient clinic where patients can be evaluated and receive care for similar issues that they may otherwise go to the ED for, and unmeasured patient factors that were not captured in our data set. Further exploring these factors should be the focus of future work to identify opportunities for us to improve care for our patients undergoing ambulatory surgery. Thank you.